Hey David, that was really excellent. This is Jerry.
Good evening.
Hey. Yeah, wonderful. That was really comprehensive, concise, and straight to the point and very understandable. I'm going to start off with a few questions that my patients have actually submitted uh, to me, both in my clinic and online, about the topic that we are tackling today. And one of the more common questions I was asked was, how do you differentiate essential tremor uh, that that first developed when they were younger, and then as they got older, now they're in their 60s or 70s, they developed some rest tremor, maybe some shuffling gait, maybe some stoopness of posture, and then the primary care doctor says, "Well, you're just getting old, right?" So how do you approach such patients, especially so if they start developing this symptoms of Parkinsonism and that the drugs they use for essential tremor are just not sufficient?
Unmute myself this time. So it's a common question that we get. We often see people that have had essential tremor already. And just to clarify, again, essential tremor means the tremor is there more when you're holding your hands out or when you're doing things with your hands, like reaching out finger to nose, but better at rest than it is with activity, and been present for at least 5 years. So if someone clearly has essential tremor, it's been there for at least 5 years. And the example we just heard, 20 years or more. And they start to have some rest tremors. That actually can be seen with Parkinson's disease, but essential tremor over time does develop a resting component, okay? What we don't usually see is a very severe resting tremor in the legs, for example. So if the leg is going up and down by itself, even just sitting flat, feet flat on the ground in a chair, that's a big red flag. There's something more going on. But oftentimes it's hard to sort out because the tremor at rest isn't as bad as the tremor with activity, but it's definitely worse than before. And it's much worse on one side than another. Essential tremor is usually more symmetric, and usually more similar on both sides than we see with Parkinson's. And as we get older, it's true, we may stoop and we may shuffle for other reasons than just Parkinson's. So this is an example where the DAT scan can be useful. So I don't order it in every case. And I have a lot of cases where I'll even make fun of my colleagues for ordering it because it's so obvious that this is Parkinson's disease, but this is not one of them. This is one where they're shaking so much, I'm trying to decide they have that bradykinesia and I really can't tell for sure. And that's hard to sort out, and the DAT scan may be very useful. One other thing I'll tell people, some people say, well, why do I have to do a scan? Can't you just try some treatment? And it's true, we can do a treatment trial with carbidopa-levodopa, but as I mentioned earlier, some people may have tolerability issues, and not everyone's Parkinson's tremor responds just to one medication. They may require a combination of several meds that require careful monitoring for side effects. So before we go on that whole odyssey of trying all different drugs, I'll often encourage people to go through the trouble of the DAT scan first.
Yeah, I agree with every point that you made with your explanation. And with the distribution of the tremor, though, suggests more ET versus speedy or the other way around. Like, for instance, a jaw tremor or a yes head tremor or a no head tremor or a leg tremor. Do any of this tremor, or a voice tremor for that matter, would the distribution or area involvement of the tremor be suggestive of one versus the other?
Yeah, so if someone's already had essential tremor for a long time, it's very common to see head and voice tremor as well. But when we're first diagnosing someone, it's more common, especially in an older onset patient. And now that I'm approaching 50, older to me is 50 and over. But we generally define young onset below age 50. Some young onset patients are more likely to have a little head tremor. But another important feature is if someone has prominent rest tremor in the legs, they're sitting in a chair and that leg is shaken on its own, fully supported at rest, especially if it's unilateral, that's generally not essential tremor. So that's another important feature, is if it's rest tremor, prominent rest tremor in the lower body.
Yeah, I just want to add that I think in my experience, the jaw tremor as well is just statistically more common in in Parkinson's patients than it is in
Well, actually, there's an update on that. We
Yeah.
haven't published the paper yet, but
Oh.
the Brain Bank crew is working on a study to compare people who are diagnosed based on the autopsy who
Sure.
were followed with jaw tremor, and all the specialists in the group saw as jaw tremor, and they kind of put their nickel down what it is. And it actually did not predict the diagnosis. And we have to publish the paper, but so far that's what the paper's likely to come out after all the peers review it. So it may be that even though we think in our experience jaw tremor is more common in one versus the other, the autopsy research, and at least in Maricopa County, doesn't bear that out.
Yeah, yeah. And the other caveat I want to add to that is that sometimes I see patients also with asymmetric essential tremor. In other words, although conventional teaching tells us that Parkinson's is more likely to be asymmetric and essential tremor is more likely to be symmetric, sometimes I see patients with Parkinson's with symmetric symptoms, and I see sometimes, patients with essential tremor with very asymmetric, sometimes even just one-sided symptoms. So if you have it becomes very confusing, for instance, for somebody to have started with a postural and action tremor of one hand, and then down the road develop, some rest tremor of that hand. And the question is this Parkinson's or is this just, chronic essential tremor, which is asymmetric in percentage?
Can I give you another quote? So I already told you the quote of the year is "You're on mute" for last year. But the quote I want you to take home from me, this is what I always tell people is patients don't read the textbooks.
Right.
And so we're taught that essential tremor is more often similar on both sides, but actually at least a third of cases that's not true. And vice versa, there are people with Parkinson's that still can have symptoms on both sides at the outset. So yeah, it's another clue that we look for, but we have to kind of look at the whole big picture and not just that one aspect. Yeah.
And then in terms of levodopa responsiveness, I do start some patients in the absence of a DAT scan. Whenever I see these patients of an overlap between ET and PD, I'm not really sure if this is just pure chronic ET versus ET and PD. Sometimes the response to levodopa can not necessarily predict that they have developed Parkinson's as well, especially if they've developed tremor predominant Parkinson's. And usually the clue to that is that these patients now have very severe both rest and action tremors, which more often than not is asymmetric. You give them some levodopa and keep increasing the dose, and then patients, don't respond. And then you do a DAT scan, and lo and behold, you see, the DAT scan abnormalities that seem to suggest that the patient has overlapping Parkinson's. What about orthostatic tremor? Do you see orthostatic tremor, which is, for the audience, tremor of the legs when you're standing in place, not when you're walking, not when you're seated, but when you're standing in place? This orthostatic tremor of the legs while standing, does it suggest one diagnosis versus the other?
Yeah, we definitely see that in all of our movement disorder clinics, and it is something that can be present with some of these other conditions. I've definitely met quite a few people with orthostatic tremor that also have essential tremor of the hands. It's challenging to treat, and then we also have to sort it out. There's all these different kind of medicalese, orthostatic tremor and orthostatic myoclonus. I know some of my colleagues at Mayo Clinic have suggested that primidone, which we use for essential tremor, can also help with the orthostatic tremor if it's more of a myoclonus. But it's tricky because the medications for orthostatic tremor don't seem to be as effective as often as somebody with essential tremor taking essential tremor drugs. Gabapentin, clonazepam are the main two if something's going to help. I don't know if you've seen any others.
Yeah, I agree. And what can be pretty confusing at times also is when a Parkinson's patient develops an orthostatic tremor. And the question is whether the orthostatic tremor is part of the Parkinson's syndrome or Parkinson's disease, or is this a manifestation of essential tremor? And I've actually done neurophysiology studies on such patients, and the frequency will actually help determine, whether patient has an overlapping essential tremor manifesting as orthostatic tremor. So the classic orthostatic tremor is about 13 hertz and above, so 13 beats per second. It's really, really fast. It's usually symmetric, whereas the orthostatic tremor that we see in Parkinson's disease and the atypical Parkinsonisms is much slower than that. So very rarely is the frequency more than 10 hertz. And very frequently, the orthostatic tremor in these Parkinson's syndromes is kind of asymmetric. And the kicker is some of these patients with Parkinson's disease or atypical Parkinsonism, slow orthostatic tremor, that's a term they use now, slow orthostatic tremor have actually been levodopa responsive. And we don't usually think of levodopa as a drug that we use for orthostatic tremor, but apparently in the Parkinson's population, it's something to think about. I wonder whether you've seen such cases yourself.
I have seen cases where the tremor is mainly in one leg, and that always makes me worried, that this could eventually turn out to be more of a Parkinson's type tremor. But if they don't have any other features yet, sometimes you have to wait and see how things evolve.
Yeah. And then what about the DAT scan? I and many other movement disorders specialists I've spoken to over the years have sworn that we have followed patients that look like they have Parkinson's, they're levodopa responsive long term, and yet these patients have quote unquote normal DAT scans. Mm-hmm. Are you one of those believers in this?
Yeah, unfortunately, there's kind of a fly in the ointment there. So, there were studies where they're reviewed by, international experts, eyeballing the scan and saying if it's normal or not, where, these world leaders like Tony Lang say, when they look at the videos, they can see that why this is the case, that this person has a different type of tremor. We call it dystonic tremor. Sure. So there are all these features. But when I moved to the Phoenix Valley, what I found is the quality of the scans and the interpretations varies quite widely throughout the state. And so I have very little trust in not only in the interpretation, but even in whether I'm going to get a good quality image. So it's just another piece of information. And so I always have to see the scan, see if the images look the way they're supposed to, and not just trust what the radiologist said.
Absolutely. Yeah, I do the same thing. I always insist that the patients, ask for a copy of the CD just in case my office doesn't receive a copy of the CD. Or sometimes I've actually asked for a backdoor directly from these radiology places so that if I don't receive the CD, I just, go online and check out the DAT scan images myself.
Can't emphasize that enough for the audience. It's
absolutely, absolutely.
See the pictures.
I guess the take-home message is that normal DAT scan is not always normal, right? It really depends on who's reading these films, and that, as you just said, there might be a disagreement, a discordance among different readers, and that brings me to my second question, which is not all of these DAT scanners quantify the signal, right? There's a software that they use called the DAT Quant or DAT quantification. And unfortunately, not every scanner or scanning facility has this software. And I tend to trust more those that did that quantification versus those that don't.
Yeah, I think it's useful information. When the scan was approved, it was approved based on the visual inspection. But it's another important tool that's available only at select centers. But I've also seen cases where someone has the whole history and everything, the way everything adds up, it still didn't fit in with Parkinson's to begin with. And only based on that software alone was there a subtle abnormality. Sure. In that case, the software isn't enough to make the diagnosis. We still have to look at the whole picture. Yeah, and in fact,
for many of these films that I have disagreed with, I mean, they're not floridly abnormal, to be honest. They're just what I call asymmetric. So one side seems to be a little less bright than the other side, maybe either the caudate, which is the head, or the putamen, which is the tail of that comma or that bean-shaped structure that you showed us. And the question is, when the radiologist reads this and there's a little bit of asymmetry, a little, less formed, comma in one side of the brain versus the other, many of them read this as normal, and yet And yet when I see a patient, it kind of correlates with, their symptoms are in one side, which correlates with the opposite side where the signal seems to be reduced. I kind of say, well, in the absence of that quantification, I think you might have early Parkinson's disease, and that most likely I'll try on some Parkinson's medication. And these are the patients that I actually bring back maybe a year or two after, for sure, and we'll probably do another DAT scan at that point to see whether there has been an evolution of this.
Yeah, I think this is really eye-opener for people, though. The take-home point also is the DAT scan is not a yes/no answer.
Absolutely.
Do you have Parkinson's or not? And it's just another piece of information whether there's that neurodegenerative cause of the Parkinsonism.
Okay, there's a question as how many facilities offer the DAT scan? You want to answer that, David?
Well, I mean, when I worked at the University of Utah, they were the only one in the state, and the guy that was running the program had developed the scan, so I always knew what I was getting. Here, I've lost track. There's just so many new places popping up all over the place here. There must be dozens in the state of Arizona offering it.
Yeah, and without wanting to publicize one over the other, I've actually had best experience in terms of quality of scans, at least locally, in Arizona with the Smile facilities. They just have the best scanners, the best quality. They also have in some facilities the DAT one. And what I like about their scans is that they actually give you a summary picture of the different slices or cuts, and which instead of giving you this individual cuts and you're not really sure whether you're really interpreting, it's like smack in the middle of the structure.
I've never had a patient see me for consultation where I already got the disc from Smile before the consult. So please, if you have it done there and you're seeing someone that doesn't have a way to log in the system, make sure you have it on a disc.
Absolutely. But you know what? Smile is one of those facilities, though, that you can ask for a backdoor very easily, too.
Oh, yeah. We're going to look into that.
Absolutely. And then just as a follow-up, there's actually more than one study now where they looked at these DAT scans at one point where they were interpreted as normal, and yet these patients had Parkinson's clinically and were levodopa responsive. And true enough, some of this, I forget what the percentage is, but a good percentage of these patients actually a year or two after had floridly abnormal DAT scans, which comes to show that, again, a normal DAT scan at the get-go, especially in the early stages of Parkinson's, may be misinterpreted as being normal.
Yeah, definitely in Arizona.
Absolutely. And then what about the atypical Parkinsonism syndromes? In your experience, which of those can present with abnormal DAT scans, and therefore the DAT scan doesn't necessarily mean it's Parkinson's disease?
Well, all of them that are due to damage to the dopamine system, by definition, may have an abnormal DAT scan. The first two I talked about, where it's just the lower body involved, normal pressure hydrocephalus and vascular Parkinsonism, should not have an abnormal DAT scan. The other types may, however, depending on where most of the changes in degeneration in the brain are, they may or may not. And particularly with dementia with Lewy bodies, especially if the person doesn't have classic Parkinsonism, they mainly just have the other features. It could be the DAT scan could be interpreted as normal, and correctly so. Also, corticobasal degeneration is a rare type I didn't talk about that also can have a normal appearing DAT scan. So it's just another piece of information that helps us kind of narrow things down. But just looking at another important thing I've clarified, looking at the DAT scan, it gives us some clues if it's very symmetric and both sides are degenerated equally. It makes us think more about atypical, especially if it's early in the course, because usually even the scan itself is worse on one side than the other early in the course of run-of-the-mill Parkinson's. But that's just another clue. Again, patients don't read the textbook.
Absolutely. And I just want to re-echo what you said earlier on. I think the best utility for the DAT scan is differentiating pure essential tremor from somebody with Parkinson's disease. especially if that patient with essential tremor has a resting component or has some subtle Parkinsonism. And I think the other, I agree with you as well. I think the other population of patients where I find the DAT scan to be very useful would be patients with drug-induced Parkinsonism versus Parkinson's disease. And when you're dealing with elderly patients in their 60s, 70s, or 80s, and they're given us a dopamine blocker, whether it be for psychiatric reasons or for nausea, or for migraines, and so on and so forth, some of these patients may develop drug-induced Parkinsonism. And mind you, I've seen drug-induced Parkinsonism, which is asymmetric. And you do a DAT scan, right? Because you think it's Parkinson's, and yet the DAT scan is perfectly normal. And how do you know it's drug-induced? Because you stop the drug, right? You stop the drug, and the so-called asymmetric Parkinsonism reverses.
It can be tricky because drug-induced Parkinsonism can take sometimes months, even up to a year, to completely clear up. We're not sure why, but this is well described.
Well, they've always spoken of an entity called tardive Parkinsonism. So we usually think of tardive dyskinesia. So for patients taking strong antipsychotic drugs or strong D2 blockers, whether it be for psychosis or depression or bipolar disorder. They've also talked about tardive Parkinsonism for these patients that have Parkinsonism, supposedly drug-induced, that developed early on in this course when they were given or started on a strong D2 blocker. And then you stop the drug, right? Because you recognize that this is probably possibly drug-induced, and the Parkinsonism persists. And the question is this Parkinson's disease with over the drug-induced Parkinsonism, or this tardive Parkinsonism over acute or chronic Parkinsonism from the drug?
Yeah, I think for the audience, this is just an example where it's really important to see a movement disorder specialist if your presentation is not run-the-mill, things are really complicated. This is an area where even if you put 5 specialists in the room, you'd see us arguing. Many of us would say tardive Parkinsonism is very controversial, and some papers suggest it doesn't truly exist, and we're not going to have that debate in front of you. But
sure.
It's a good example where you really need to have close follow-up with someone who really is a specialist if you have a complicated presentation.
Yeah. And then I've also seen, especially lately, I've seen some cases of vascular Parkinsonism with strategic strokes where the DAT scan was abnormal. Like, for instance, just very recently, I got a referral for somebody with hemi-Parkinsonism, acute onset. After he's a young fellow, he had a heart myxoma removed. Okay, so this is a tumor in the heart, and very notoriously, this kind of surgery is associated with emboli, a shower of emboli to different parts of your body and brain. And unfortunately, he had a strategic stroke there in the midbrain, where the substantia nigra is. That's the part of the midbrain, or the part of the brainstem that is involved in Parkinson's. He had an acute onset of Parkinson's syndrome, hemi-Parkinsonism, and I wasn't really sure. I said I'm almost certain this was stroke related, and I thought the DAT scan was going to help me. And so, and what I saw in the DAT scan though was the DAT scan in the site where that was involved in the stroke was abnormal. So this was
the cells are damaged. Even if the body of the cell is damaged, the nerve endings die back too. I've only seen this once in my career as well. So I said earlier, vascular Parkinsonism doesn't usually respond to levodopa. But I had one patient when I was still in training as a fellow. The MRI showed a stroke in the substantia nigra where the dopamine cells are, and that person was responding well to levodopa. So it's a good example where vascular Parkinsonism doesn't usually respond to levodopa, except if you have a stroke in your dopamine producing part of your brain.
Yeah. Now, in your experience of this atypical Parkinsonian syndrome, which one, especially in the early stages, let's say the first couple of years, has the highest chance of mimicking Parkinson's disease that even you, a very experienced movement specialist, can possibly be fooled?
Yeah, there's a Parkinsonian variant of progressive supranuclear palsy. And that's a condition, it's actually the second most common neurodegenerative disease after the Lewy body disorders, when you consider Parkinson's and dementia with Lewy bodies as one umbrella condition. And the brain bank studies, especially out of England, the United Kingdom Brain Bank, show that many people don't have any of the other features till more than 3 years after their other symptoms develop. It can take 5 years or more. So in the Parkinsonian variant, people can even have the acting out of dreams that make us think about Parkinson's or multiple system atrophy.
Sure.
So the Parkinsonian variant of PSP by far is most likely to throw us off.
Yeah, and I just want to add to that the Parkinsonian variant of MSA. So you touched on this, multiple system atrophy having, the Parkinsonism phenotype versus the cerebellar type, MSAC versus MSAP. And I've seen patients with MSAP that present very similarly to Parkinson's. They can be levodopa responsive in the beginning. In fact, there was at least one paper I've read, if not a couple of papers by now, over years, where patients with MSAP actually made it to deep brain stimulation because the movement specialist swore that this patient had Parkinson's disease, maybe even tremor predominant Parkinson's, and that deep brain stimulation was the only option, given that the levodopa wasn't very, very effective.
Yeah, it's very complicated, and unfortunately, we don't have a definitive test to tell us for sure how things are going to look years down the road. Because over time, people are more likely to have symptoms that fit with one of these conditions. But in the very first 3 years, it can be really challenging.
Absolutely, and in fact, there was one of my favorite papers to quote is that Mayo Clinic paper, which was published, I think, in 2015, where they looked at the pathologies of the brains of patients that were diagnosed with Parkinson's disease. And they found out that even among movement specialists, the rate of misdiagnosis within the first 5 years is somewhere in the range of about 42%, especially in patients where levodopa, a good levodopa trial has not been instituted for one reason or another, whether it be poor tolerance or just patient is just not severe enough.
That's true. Yeah, one of those papers from right here in Sun City. Yeah,
I know, right?
Yeah. So then, early on, the accuracy is not as good as once we followed someone for more than 5 years and continue to see response to levodopa.
And then for your MSA patients, the MIBG scan is actually available locally now. It's being done. The MIBG scintigraphy is actually available in different radiology places. I've actually done a few patients that I had difficulty differentiating between Parkinson's disease with autonomic dysfunction, just prominent dysautonomia versus is this really early mild multiple system atrophy. And to me, that's where the conundrum very often lies, just differentiating these two conditions first, especially when the condition is not fully developed yet. And most conditions can have abnormal DAT scans. Both conditions can have some levodopa responsiveness, or even worse, if they're not bad enough to have a levodopa channel, it's really difficult to differentiate one from the other. And then if you do an alpha-synuclein skin biopsy on these patients, given that they're both synucleinopathies, the alpha-synuclein skin biopsy is really not very helpful. And that's where I think the MIBG scan can be helpful. The papers have shown that the MIBG scan is abnormal even in early Parkinson's disease, and in general is normal in multiple system atrophy.
For the audience, it's kind of like a DAT scan except for the heart, and Exactly. It shows loss of the nerve endings to the heart that release the noradrenaline. That's kind of like dopamine, but helps your body react to the change in position when you stand up, so your blood pressure doesn't drop. And it does seem to be reduced. The nerve endings to the heart for the sympathetic nervous system are really damaged and die back in people with the Lewy body conditions like Parkinson's and also dementia with Lewy bodies. The problem is the scan is not formally FDA approved in the United States to differentiate these conditions. So it's a very expensive test. And also we don't have people that are trained to interpret it. I don't think I feel comfortable interpreting it. But I think if we could get to that point where there were people trained to interpret and there were a way to get it covered, then it could be a useful test. It is actually on the guidelines for diagnosis of dementia with Lewy bodies, but with the asterisk not yet formally available in the US. not FDA approved in the US.
Not FDA approved, yeah. And then you talked about levodopa responsiveness or lack of, or non-durable effect of levodopa for this atypical Parkinsonism. So I guess my first question is, how much do you push that dose of levodopa before you say, okay, patient is not levodopa responsive? Or the other question is, if they are levodopa responsive, how long should you wait before you can say, yep, this patient is out of the woods, definitely levodopa responsive, definitely has Parkinson's disease?
Yeah, I don't think there's a consensus on that. And there are some doctors who are very aggressive in all patients. But the important thing is it's case by case, because in someone who looks like they likely have Parkinson's, but they're just not responding at a moderately high dose, like 600 milligrams total a day of levodopa. If I keep pushing the dose, I really increase the chance they're going to have complications of levodopa therapy, especially dyskinesia. Mm-hmm. So I may use a combination therapy approach if I still suspect Parkinson's. On the other hand, if someone has that corticobasal syndrome where one side of the body seems to be forgetting how to do things, we call it apraxia. There's a funny posture to the hand and it's painful spasms, and there's no improvement as we get to 600 milligrams a day, but it's making people really sick. If I'm really suspecting the corticobasal syndrome, I won't necessarily push really high because it doesn't work for most corticobasal syndrome patients, and they just have a lot of side effects and they lose weight because they can't eat. However, if I suspect PSP or multiple system atrophy, and I'm seeing slowness of movement in the hands or gait freezing problems that I feel could respond and improve the quality of life of that person, because it could improve muscle stiffness, it can improve fine motor skills or gait freezing, I may push as high as 1,200 milligrams a day with PSP or MSA. So it's really case by case, and also based on getting the whole story and deciding which condition am I thinking is likely present. And I think that's the difference when you see a general neurologist that's not comfortable or experienced enough to use all the diagnostic criteria, or they just don't have the time to get the whole story. They're not going to think along those lines. And that's where the atypical Parkinsonism is a very good reason to refer out, even if they're very comfortable with run-of-the-mill Parkinson's.
And then of those atypical Parkinsonian syndromes, you mentioned dementia with Lewy bodies as being notorious for having cognitive issues and dementia even early on. But do these other atypical Parkinsonian syndromes, are they also associated with earlier dementia compared to Parkinson's?
PSP, progressive supranuclear palsy, is associated with an early frontotemporal type dementia, but it's a very different type dementia where you have problems with language or changes in behavior, becoming more impulsive. But very different kind of problems than we would see with the other types of dementia. You don't usually see severe memory loss with PSP. And if you do, and it responds to medications that usually help with memory loss in Lewy body dementia, that would suggest it's not PSP. The other thing is with MSA, it can cause dementia late in the course, but it only causes 7% overall, and about 40% have mild cognitive impairment, but it should not cause early severe dementia. So you bring up an important question. If someone has severe orthostatic hypotension, but they also have dementia, the most common misdiagnosis I see from my colleagues, where I'm really glad they referred, is the patient has dementia with Lewy bodies, not multiple system atrophy, but they're calling it multiple system atrophy because of that orthostatic hypotension, low blood pressure standing up. But if they already have dementia and they have the other features like hallucinations, that is not MSA, that is dementia with Lewy bodies.
Yeah, I just want to add a caveat to that, in that I myself have been fooled in a patient that later on had floridly obvious dementia with Lewy bodies. In the early stages, I actually sent her to a neuropsychologist when I suspected early dementia with Lewy, hallucinating, autonomic dysfunction, orthostasis, and so on and so forth, and Parkinsonism, which was asymmetric, somewhat levodopa responsive. And then the neuropsychologist said, nope, patient is not demented, so it can't be dementia with Lewy bodies, right? And so we were beating around the bush for about a year or so. That scan was abnormal. So again, that doesn't help me in terms of differentiating Parkinson's from dementia with Lewy bodies. And then only about a year after, when I said this has to be dementia with Lewy bodies, because patient now is much more much more demented, at least at home and clinically she was, and the rapid onset of the dementia over a year, or progression, I should say, over a year, and the increased hallucinations as I increased the dose of levodopa. So I guess in the early stages, when dementia Lewy bodies presents to your office in the very early stages, sometimes it's not very obvious.
Yeah, very tricky, because the definition of dementia varies depending on what your previous function was. So for somebody who is an engineer, they have a very high kind of baseline, and so for them to decline to where we call it dementia, may take a lot longer. So it's somewhat of a interpretation we call subjective in medicalese, that based on kind of what each neuropsychologist is saying based on their opinion, if this fits or not. But also, is it interfering with everyday activities? And some people have much more complicated everyday activities, more room to interfere than others. But yes, I agree. That is a really important pitfall. And unfortunately, dementia with Lewy bodies is the second most common neurodegenerative cause of dementia, and it's a lot more common than we realize. So the diagnosis can be missed early on. And that's where I would point out that the neuropsychological testing is another piece of information, but that information then needs to be put together with the whole story by an experienced neurologist who sees these things and has time to be fooled early in their career and then learn from their experience.
Oh, absolutely. One thing that's even more confusing is I've had patients with Parkinson's and Alzheimer's disease, almost concurrent, because these are two neurodegenerative disorders that can develop as you get older, right? And I've had some patients who I thought had dementia with Lewy bodies, and I ask for a neuropsychological test. I also ask for a neuroquant, which is quantification of the volumes of the temporal lobes for the audience, especially the medial part of the temporal lobes, which usually atrophies early in Alzheimer's disease. And I've seen a couple of these patients in my practice now that were diagnosed, at least I thought had Parkinson's disease with Alzheimer's, when in fact they presented early on with a picture that is very similar to dementia with Lewy bodies. Although I'd have to say, though, I don't think hallucination was a prominent issue in these patients.
Yeah, and something we're learning now because of these brain banks like we have here in Arizona is for people with Parkinson's who have dementia, about half or more of them also have Alzheimer's disease in our brain bank. And people who have dementia with Lewy bodies, the majority, almost 80%, at least in our brain bank, maybe more, have both Alzheimer's disease and dementia with Lewy bodies. So the rule is combination. It's actually the combination, not the exception. It's actually the rule to have more than one problem. So it's very common to see both. And when someone starts with Alzheimer's but also has dementia with Lewy bodies, the Alzheimer's may mask some of the dementia with Lewy bodies symptoms. So we're still working hard to find better ways to diagnose those people, because the symptoms may not be as obvious if you start with a lot of Alzheimer's but also have dementia with Lewy bodies.
Yeah. And then the other very tricky set of patients to take care of, especially in trying to differentiate Parkinson's from the atypicals, is patients that present to your office with freezing of gait, especially in the early stages of their Parkinsonian syndrome. So do you have any tricks to share with us on how you differentiate, Parkinson's disease from these atypicals when the initial and most prominent symptom is freezing of gait?
Yeah, so there is a subtype of progressive supranuclear palsy, PSP, that starts mainly with gait freezing. They have all these different acronyms like PHE, uric-agenesia, and gait freezing. And what I've seen, I've only seen this a couple times in my career, but what I showed on the MRI earlier, there are things we look for there with the shrinking in the midbrain.
Sure.
In the midbrain. Also, we don't just look at whether you can look all the way up and then all the way down. And yes, we can still do it on telemedicine somewhat. But we're also looking at, if you look right at the camera, then look down at the floor, then back to the camera, back and forth. We're looking at the speed that you can move your eyes between two targets, the saccade speed. And if the vertical saccades are slowed and the person has early severe gait freezing, chances are this is going to turn out to be that variant of PSP, which fortunately progresses more slowly. But early on, those may be the only features. We may also see some subtle Parkinsonism as well. But early severe gait freezing is a big red flag that it may not be Parkinson's. However, if the person still has other features, like one side is worse than the other, they have the slowness, stiffness, rest, especially if they have rest tremor. But if they don't have rest tremor, but they still have slowness, stiffness, and everything responds well to levodopa, that's still reassuring that the gait freezing was actually due to that slowness of movement, the bradykinesia. So it's really the whole big picture, getting the whole story, doing a thorough exam. But yes, they don't necessarily have to have the severe balance problems for it to turn out to be PSP if there's early severe gait freezing.
And would a trial of levodopa help you differentiate one from the other?
It depends how we're measuring things. It really depends on the whole picture. So, it's something where you can't just have a general neurologist that, is certified in epilepsy saying, okay, I'll give you a trial of levodopa, and if you respond, you don't have Parkinson's. No, we have to look at the whole big picture. Okay. Also, we need to think about, well, if it's just gait freezing, just trouble walking, and nothing else, we need to look at the MRI scan, because like I showed earlier, it could be one of those other types, the vascular or the NPH.
So aside from looking at the sizes of the ventricles and the CSF tap test, do you do any other tests for NPH?
Yeah, I mean, the important pitfall with NPH is the gait problem needs to be present. And so that's the most important thing, is looking at the gait. If someone does not have a dramatic response to their tap test, we do the spinal tap, we do the timed walk, but everything else fits. We really look carefully at the MRI, we review it with colleagues, everyone agrees this isn't just due to shrinkage atrophy in the brain, the ventricles are enlarged. They also have the other features, so we get the whole story. They do have some mild cognitive impairment problems and bladder urgency. If everything fits, just failure to respond to the spinal tap tests alone doesn't necessarily mean it's not going to respond to a shunt. And I will refer them to consider what's called extended lumbar drainage, where we do 72-hour drainage. Yeah. And the neurosurgeon has to arrange that. And before COVID, we could do it in the hospital. For now, we're holding off on that until everyone's gotten vaccinated.
Absolutely. I've also seen a number of patients with NPH in my practice. I sent them over for BP shunting, and some of them have let's say a 50% response, and they're still left up with some gait impairment. Or I have some patients that initially responded very well. Then I followed them up every 6 to 12 months, and then down the road they develop more Parkinsonism, and I have this shunt checked out, and the shunt is still working. So the question is, what happened, right? Why is there gait impairment coming back? NPH is supposed to be one of the reversible causes of lower body Parkinson's, and it's supposed to fix it permanently as long as the shunt doesn't malfunction. So believe it or not, I've actually done DAT scans on some of these patients with apparent pure NPH in the beginning, or that did not respond night and day from the shunt, and I'd say a good 5%, if not almost 10% of these patients have an abnormal DAT scan, and therefore they have, kind of two disorders, NPH is Parkinson's. And the way I prove that is I give them levodopa. And if I'm able to, improve the gait, with that levodopa together with the shunt, which I confirm is working, then I kind of say, okay, this must be two disorders, NPH is Parkinson's. Yeah,
I've definitely seen people that have both, and I've seen people that get shunted even though we weren't, they weren't sure whether the response to the tap was robust. But as things evolve, it's either Parkinson disease or more often one of the atypical Parkinsonisms, unfortunately.
Yeah. Here's one question from the audience. How often do you see concurrent MSA and Lewy body disease?
So the problem is, in order to diagnose that, you'd have to have, the person donate their brain for an autopsy. There's no way to say for certain that they have both. You need that definitive diagnosis. And there may be reports out there. If you search PubMed, you may find a couple, but I haven't personally seen that reported in our brain bank. And I think we've had, we don't have very many patients that turn out to have MSA in our brain bank to begin with, but over, I think, 1,600 brains donated here over the last 30 years. And I don't think any have had that combination. But, it may be out there. But more often, how often do I see DLB, dementia with Lewy bodies, misdiagnosed as MSA all the time?
Yeah, absolutely.
And I was guilty of that early in my career, more often than I am now, but it still happens to me.
Yeah, but as you said, most MSA patients develop, dementia really late down the road, and only a small fraction of them get floridly demented.
Yeah, but unfortunately, many doctors don't seem to understand that if someone has dementia with Lewy bodies and then they develop that low blood pressure standing up, that doesn't mean they now have MSA.
Yeah. What's more confusing though is MSA patient who develops Alzheimer's disease, because that can mimic dementia with Lewy bodies.
Well, unless it's been confirmed with an autopsy, if they have that presentation, I wouldn't necessarily believe you that they have Alzheimer's with MSA. I still think dementia with Lewy bodies.
Yeah.
We're looking for, when you hear hoofbeats, you think horses, and DLB is definitely the horse when it comes to that presentation.
I guess the caveat is still to simplify the diagnosis. If you can explain everything with one diagnosis, then so be it. But if the picture really doesn't fit with just one diagnosis, then you're kind of forced to make more than one, and rarely even more than two, but very rarely. Okay, hey, thanks so much, David, for this exchange. I really learned a lot from your talk, and I think the audience really learned a lot as well and enjoyed your talk.
Yeah, thank you for having me.